Next we have Dr. Nishanth on stage.
Dr. Anand Parthar, please, on stage. Very good morning to everyone here. So, I'm going to talk about the presbyopic lasers. Yes, we had a very detailed discussion by Dr. Jayanthan, who told about the glasses and the contact lenses. So, now I go to the next layer where we have already started having presbyopic laser correction. Yeah, it is a little a difficult topic, which I will try to make it as simple as possible. Uh, as Dr. Jayanthan has told about all the possible options in the spectacle contact lenses, I'm going to the next topic where we have the surgical correction. There were surgeries like the conductive keratoplasties, which I think has become obsolete, and there are few corneal implants and intracore as well. What about the dynamic presbyopic corrections? We had the accommodative IOL, the lens refilling, the lensectomy, which was lenticular, and the scleral procedures. We had some scleral expansion devices where we had to make sure that they are trying to read the near visions. Then came the corneal approaches, where we had monovision Lasik for a long time, then creating a corneal multifocality and the combined approach. So we realized that creating multifocality is possible with the laser advances which we have, where we call the central presbyLASIK, which is either the supracore or the presbymax, the peripheral presbyLASIK, which is not done, the laser blended vision, which is the presbeyond. So I'm going to talk more about the presbymax, which is from the Schwind. So what is monovision? So we know that it's only for the distance for the dominant eye, and the other eye we correct up to around 1.5 to 2 diopters to make for the non-dominant eye for them to see near. But what is the disadvantages? Yeah, one of the disadvantages is the stereopsis is completely lost and anisometropia more than one diopter. But yes, you do have clear focus. If you counsel the patient and have a good chair time with them preoperatively, you can actually tell them that please do not compare your eyes for distance and near. You see it binocularly. You make sure that you put that lens before the surgery and tell them to get adapted to whatever power they are having, and then they get adapted to it if you start preoperatively itself. And the pupil size doesn't matter for this monovision correction. So these are the two types of mode where you have this distance vision is which is for the what the peripheral mode means is that the central is for the distance and the mid periphery is for the near. But the central mode where we have something similar to all these multifocal lenses, which Dr. Jayanthan said, is where the central is for near and the mid periphery is for the distance. And what is the advantage in that it covers a whole range due to different foci for distance, intermediate and near, and it is also a bilateral procedure, but the only thing is it is pupil dependent. The main disadvantages are it takes time for adaptation and there is a drastic reduce in contrast sensitivity because we are bending the light in different focus. So I'm just showing a highlight of what supracore was. So it is a central presbyopic Lasik where the cornea is made, the central is for the near addition, and then you have the intermediate distance. And presbyon, which is by the Zeiss, they call something called the blend zone. So this is also working in terms for the spherical aberration. They actually create a spherical aberration to the patient so that the patient has a difference in the focus. And what does the Schwind does is, the best thing the Schwind does is a bi-aspheric design. So you have a central position for the near, and then you have the intermediate, and then you have a periphery for the distance. So this actually also uses a monovision correction, but the central is for near, making the patient more myomic in the non-dominant eye. So as I told you, it is a bi-aspheric multifocal ablation profile. So it is similar to the principle of these multifocal lenses. The term bi-aspheric refers to the optimization of the central cornea for near and the mid periphery for far for each patient's eye. So I'll just show you a small picture what it depicts. So this was actually this symmetric presbymax we don't do nowadays. So let us take for instance that this is the distance and this is the near. A long time back they used to keep the dominant and the non-dominant eye both make them myopic for around approximately -2 and the intermediate for -4. But then they realized that the depth of focus was very high. So then what happened is came the micro monovision concept where it was half reduced. So once they reduced and made the distance plano. So in this, if you see that the distance is plano, and then for near they kept it around -1.5, whereas the non-dominant, if you see that the full central near is corrected and there is around minus zero point 0.8 diopters. This minus zero point 0.8 diopters is the most significant because this helps in making the stereopsis possible. From micro monovision, what happened? So they brought the hybrid monovision. So then they realized that this also didn't have too much of depth of focus. If you see for the near, it is for the distance it is 1.5 and for the near it is 0.8. So when they brought in for the hybrid for micro monovision, then you see that the depth of focus for distance is around 0.7 and depth of focus for near is around 1.4. So same way they reduced it into half for the dominant and the non-dominant eye. To just summarize in terms of a single picture, let us take for example there is a patient who is having an addition of plus 1.7 diopters. In the micro monovision, the dominant eye, which is for distance, is going to have a full correction, whereas the patient is going to be completely corrected, and for near it will exactly be the half. The quarter. The quarter of this will be there for near. And for the hybrid, the distance is corrected. Let's come out to the non-dominant eye later. So for the distance, it's completely corrected and it will be half of what we are correcting for near. And the monocular, we know how it works, where the distance is left plano. Only the near we do the correction for monocular vision. So the only difference for the monocular is these are the patients who are not having any distance for myope or hypermetrop. The patients who are most comfortable in which we have done is mainly the hypermetropes with presbyopes. So I never do it for myopes with presbyopes because they are always having a good vision for distance and they are always comfortable without glasses for near. And suddenly if you make sure that they are able to read near but you're losing that 6 parts for the distance, they're a little unhappy. So my preferred patient selection is always hypermetrope with presbyopes and not the early presbyopes who are just come between the age of 40-45. I always go up to 48 or 50 where they at least have an add of approximately around +2 diopters or 1.75. When they just start getting one, that means that after around 5-6 years we will have to recorrect if we are doing it very early stage. So they have done a study for the micro monovision. I have around 5 years follow-up of these patients who are very comfortable, but the only thing is the counseling and the chair time. One more important thing is what are the prerequisites. So my always choice is hyperopes, we do the micro monovision. For emmetrope, it is the mono vision correction, and for myopes we do the hybrid correction. And as we are doing this for the age of nearing around 50, we should always make sure that you evaluate the lens with a detailed fundus examination. Sometimes undilated it might looks like there are no changes, but always talk to the patient that they might require a cataract surgery later on. And also as they age, you should always look at the tear analysis, the meibography, and also the internal aberration, because this can also be a corneal wavefront guided procedure for the presbymax. As long as the patient is not having any higher order aberrations, I would not correct them as well. So this is how the mechanism works. There is a static cyclotorsion. You can see that this is the distance eye is the dominant eye. So for the right eye, we do a presbyopic add of +2. This we are going to do the hybrid correction. So in the hybrid correction, you can actually see that the patient is accepting +0.5 with a -0.5 cylinder, but the target, as I said, it goes to -0.89. So the laser which is going to ablate for the right eye with the left eye being dominant is around +1.36, so that we get a target of -0.89. And if you see the dominant eye, which is for distance, we actually just correctly complete the full correction of whatever the patient is accepting. But I will show you the profile now, which also corrects for the near. So this is what the profile it looks like. You can see it is exactly how the laser is being done for the right eye, which is the non-dominant eye at the mid periphery, that is at 6.42 mm. You have an ablation of 23, and you have a small correction in the center. Vis-a-vis, if you go to the other eye, you can see that center there's around 9 microns which is corrected, and in the mid periphery that is at 3.57, there is 20 microns. So you can see that it's not only in the center, intermediate, and far. To summarize, it works. Yes, patients are metrope for distance most of the time. The most happy patients are hyperopes, and astigmatism correction can be also done completely. Near vision is pure magic, and it does work for pseudophakic patients as well. And the final thing, after around a year's time, the patient is not unhappy with it. Yes, presbymax reversal is also possible, where we just correct whatever acceptance they are having. Thank you. Any question?
Thank you so much, Dr. Nishanth. It was a very detailed presentation with all the examples. So I have a,
Yes.
I will be speaking next, but I have few questions.
Please.
So do you keep updating the machine as and when the Presbyon gets updated?
Yeah, so this in Schwind it is Presby Max. Presby
Okay.
on is the Zeiss one.
Right.
So what they have, I have not updated for the past 7 years. So it is the same module which has been there from the beginning. Because the Schwind Amaris has brought this. The previous Schwind did not have this Presby Max.
Okay.
Another small thing. One was, do you prefer to do it under the flap, or would you
Yes. So that's a good question. My preference is always with the flap.
flap?
But
Any specific
they have
reason?
not said it is not possible. Just that above 2 diopters, if they are hypermetrope above 2 diopters, they are saying that the trans-PRK also can be done. Yes, it does work.
The questions for the earlier procedures were in terms of regression. So what happens in some patients?
So
is it
yeah,
tends to
so that's
regress.
what exactly I'm in the 5 years. Maybe in another 2 years, those patients might come back. But as long as these 5 years follow up, which I have, none of them have come back with any difficulty or regression.
Last question, at least in my experience, I find the tolerability where patients don't want to compare the eyes about -1. Beyond that, if you make them 1.52, they somehow don't feel there's a significant drop in their patient satisfaction and in vision. So I think -1 most people are able to tolerate. What is your experience?
Exactly, sir. That's why this monovision correction, which is more than -1.5, I think patients are not tolerating, because one, the stereopsis, contrast sensitivity all goes down drastically. Yes, I would also agree with you and keep it. That's why the laser makes the target of 0.89 diopters. Exactly. Nice question. So that is actually a different part where they say that only negative aspheric lenses we should not use. Apart from that, the calculation is according to the normal protocol, like if you put an ICL, because it does not change too much, because it is only the central part which is going to get flattened. So the calculation for the IOL is also not going to be affected because of the procedure per se. But people ask me, because you've already created a multifocality, what happens when they want a multifocal lenses? Yes, you can post aspheric lenses. It is possible. Just don't put a negative multifocal lenses. Yes, yes, whichever is, I mean, yeah, so always any post Lasik, I always take three calculation. I do an immersion, I do a master, and I also calculate with the ACRS calculator. So I always do these three, because I have not, I mean, yeah, I have listened to everything. I have not got a single perfect this thing where I follow these barrettes. It is 100% sure that post op is. So for the benefit, always take three, decide which is the best, and that's what I practice.